Welcome back, everyone. Hope you enjoyed your break. We now have our final session for the day, which is our last keynote speech. Professor Phil Batterham from the Centre for Mental Health Research at the Australian National University will talk to us about understanding and preventing suicidal behaviour in the general population. So over to you, Phil.
Hi, my name is Phil Batterham. I'm from the Australian National University, and today I'm presenting on Ngunnawal country, and I pay my respects to elders past, present and emerging. I'm going to be talking today about research we've done to better understand and to prevent suicidal behaviour in the general community. So a brief summary of what I'm going to talk about today. First, I'm going to give a bit of background about suicide in Australia, defining what suicidal distress is and what it looks like. Talking a bit about some suicide statistics, some of the risk factors for suicide, and then I'm going to be talking about some of the research we've done to better understand suicidal behaviour in the adult population, and looking at a specific theory around why people engage in suicidal behaviour. Then I'll talk a bit about preventing suicidal behaviour, which is a fairly broad topic, but I'm going to be focusing specifically on research we've done around stigma and its relationship to help seeking among people who are experiencing suicidal thoughts and behaviours. And then I'll finish with some conclusions. So starting with some background. So suicidal distress occurs on a spectrum. So you can see on the right here, there's people might encounter suicidal thinking or suicidal ideation. They might progress to having a suicidal plan or preparation for a suicide attempt, and then to suicidal behaviour such as suicide attempts. And unfortunately for about 3,000 Australians per year ending with suicidal death. People don't always move along this spectrum in the sequence shown here. There are some people who don't plan suicide attempt, but do have a suicide attempt. So people can move back and forth along this spectrum. So there are a range of different sort of indications of suicidal thinking and suicidal behaviour along the spectrum from suicidal thoughts. And this can be passive thoughts thinking about death, or more active thoughts thinking about suicide, all the way down to suicidal behaviour. And it's important to note that there are different risk factors that influence each of these things. So there are a different range of risk factors that influence whether somebody develops suicidal thinking compared to those risk factors that are associated with suicide attempt. There are some risk factors, obviously, that overlap between those two things, but there are also a number of differences there. As you can see here, it's a bit like an iceberg. At the tip of the iceberg, what we see in the community and in health services are suicide deaths. Those are fairly accessible in terms of how many there are per year. There are about 3,000 suicide attempts per year, and this is tracked through coronial reports. It's not always easy to ascertain whether a death has been suicide or not. So for that reason, it sometimes takes a while to ascertain how many suicide deaths there have been in a year. In terms of suicide attempts, so some of these occur in the community, so they're not seen in medical settings. People don't always end up in hospital or end up at their GP when they do attempt suicide. But we do know that there's somewhere between 60 and 80,000 suicide attempts per year in Australia. And then further down, we see suicidal ideation, much more common. Approximately 600,000 people per year in Australia experience suicidal ideation. Although again, depending on how you define suicidal ideation, those numbers can vary quite a bit. So what we see in the community are suicide deaths and medically treated suicide attempts. They're quite countable because we know how many people present to hospital and how many people die. It's much harder to get a handle on how many people attempt suicide in the community and how many people experience suicidal thoughts. So these data come from the National Survey for Mental Health and Wellbeing, which was last conducted in 2007 in Australia. In terms of suicide deaths, we can see there's the pattern over the past 15 years is shown in this graph here. You can see from this that males have much higher rate of suicide deaths than females. So about 75% of suicide deaths are accounted for by males. But if you look at suicide attempts and suicidal ideation, the prevalence is actually higher in females. So we see a reversal of this trend. But these are data for Australia. So it's the annual rate of suicide deaths per 100,000 people. So for males, you can see that's fluctuated between about 15 and 20 per 100,000 males, annual suicide deaths per 100,000 males over the last 15 years. And for females, that number has been around 5 deaths per 100,000 females annually over the last 15 years. You can see there's a slight upwards trend that follows from back in the 1990s. The levels were higher than they are currently. That decreased down to around in 2000, but has had a slight steady increase since then. The age groups with the highest rates of suicide death are those aged between 30 and 34 and 40 and 44. These are around 18 per 100,000 of the population, so it does vary over age groups. But if you look at the proportion of deaths accounted for by suicide, that's highest in the 20 to 24-year-old age group, where over 1/3 of all deaths are due to suicide. It's partly because people aged who are younger adults don't tend to die from other causes as often, such as heart attacks or cancer. But we do see a large proportion of suicides in younger adults, a large proportion of deaths being suicide in younger adults. And suicide is the most common cause of death for Australians aged 15 to 44 years old. So my focus today is talking mostly about data from the general population, and most of my work is in adults, looking at suicide risk in adults. I've also tried to draw a little bit on some of the implications for suicidal distress in people with autism, although that's not my specialty area. So I'm going to talk a bit more about understanding suicidal behaviour and why suicidal behaviour happens. So it's a very complex picture. There's a whole constellation of risk factors that influence whether somebody experiences suicidal thoughts or engages in a suicide attempt. And I've sort of roughly clustered those in here. There are social factors that influence suicidal behaviour, such as isolation, and also relationship breakdown, which is also a sort of life event, a difficult life event. Other life events such as trauma, violence, unemployment, or financial pressures can also influence suicidal thinking and suicidal behaviours. There are demographic features. We've already shown you that age and gender are associated with suicidal behaviours. There are a range of psychological factors that influence suicidal thinking in particular, but also suicidal behaviour. So things like rumination, which is not being able to stop thinking about the same things over and over again, and mastery, feeling like you can enact change in your life, as well as personality factors and feelings of hopelessness that things won't change. Obviously, there's a strong mental health component in suicidal behaviour, not just confined to depression, but also to anxiety, other mood disorders, as well as substance use and psychosis. And physical health problems are also maybe associated with suicidal behaviour, as is limited access to health services. Previous suicidal experience is one of the strongest risk factors for suicidal behaviour. So having previous suicidal ideation, not surprisingly, and having previous history of suicide attempt greatly increases the risk of future suicidal behaviour. So it's very complex, trying to understand why people attempt suicide. there are a range of different interacting risk factors. Suicidal ideation is much more common than suicide attempt, as I showed you with that iceberg picture. So it should be noted that most people with suicidal thoughts don't go on to have a suicide attempt. So even if they have a range of risk factors, it's such as previous suicide attempt, in most cases, people won't go on to die by suicide. It's important to develop better theories and better understanding, though, of the processes which therefore lead people from going from having thoughts about suicide to action and enacting a suicide attempt. So a lot of the theory and research in the area is trying to understand that process of why people go from thinking about suicide to then going and attempting suicide. So one of the more prominent theories over the past sort of 10 to 20 years has been the interpersonal psychological theory of suicidal behaviour. So this was developed by Thomas Joyner, who's a psychologist and researcher from Florida. And he suggested that there are these interpersonal risk factors which have a very psychological component as well that influence whether somebody's going to experience suicidal thoughts. And because he's a psychologist, he liked to use big names for these constructs that he wanted to focus on in his theory. So one of these is thwarted belongingness, which is a sense of isolation or an unmet need to connect with broader community. And the other is perceived burdensomeness, which is this idea that you're a burden on others, that you don't feel valued by other people, or that you're a liability to other people. And his theory was that people who had both of these characteristics or feelings, sort of belongingness and perceived burdensomeness, were much more likely to have a desire for suicide or suicidal thoughts. However, it's only in the presence of this third construct, which is called suicide capability or capability for suicide, that it's more likely to see a suicide attempt occurring. And you can see this sort of captures that idea that suicide attempts are much less likely than suicidal ideation, because it's only that small sliver of the circle where people have all three of these things, thwarted belongingness, perceived burdensomeness, and suicide capability, that you are actually likely to see somebody wanting to, having a suicide attempt. And suicide capability arises, according to Thomas Joyner, from a mixture of increased pain tolerance and low fear of death, among other things. So this theory actually fits quite nicely in explaining why there are so many different risk factors for suicide, and potentially how these interpersonal constructs might influence suicidal behaviour. So we've looked at this in a few research articles and a few different studies to look at where these different sort of risk factors for suicide fit in to this interpersonal psychological theory. And we found that things like relationship breakdown, isolation, perceived lack of social support, not surprisingly, these things are closely associated with thwarted belongingness. Whereas some of the sort of psychosocial risk factors related to financial pressure, and then health problems, substance use, and some of those psychological variables such as rumination or hopelessness are more associated with perceived burdensomeness, so feeling like you're a burden on other people. Then in terms of capability for suicide, there's a range of other factors that might feed into that, such as exposure to trauma or violence, and being in a high-risk occupation. And males tend to have higher levels of capability for suicide than females. You might also notice there that high mastery is associated with higher capability for suicide, whereas low mastery is associated with higher perceived burdensomeness. So there might be these opponent or different processes that happen with some of these psychological constructs, where in some cases they can be protective against suicide, and in other cases they can be risk factors for increased risk of suicidal thoughts or suicidal behaviours. So this is an interesting model, and it's useful for explaining why, in some cases, why people might engage in suicidal behaviour. We've actually looked at the evidence for this theory in a large systematic review that was published back in 2016, led by one of my PhD students, Jennifer Ma. And she looked at the evidence for each of these constructs and whether these interactions between constructs were associated with the outcomes of ideation attempt along the lines of what the model or the theory would hypothesize. And she actually found that there wasn't a whole lot of evidence for the effects of thwarted belongingness by itself on suicidal ideation. Only 40% of the studies found a significant relationship between thwarted belongingness and ideation. The evidence for perceived burdensomeness was much more compelling. So you can see there's almost 70 studies looking at the effects of perceived burdensomeness on suicidal thinking, and 83% of those found a significant relationship there. So very strong and consistent relationships between perceived burdensomeness and suicidal ideation. When you look at capability for suicide, only about 9 studies had looked at that, and about half of them found that capability was associated with the suicide attempt. When you look at that critical interaction between thwarted belongingness and perceived burdensomeness on suicidal ideation, there haven't actually been many studies that have fully tested the theory, because the idea is that you need both of these to be present for ideation to occur. And from the 12 studies that have looked at that back in 2016, we found that about 2/3 of those studies found the significant interaction effect, suggesting that both thwarted belongingness and perceived burdensomeness needed to be present for a suicidal ideation to occur. It's actually quite hard to find a 3-way interaction between thwarted belongingness, perceived burdensomeness, and capability or acquired capability for suicide, which is what the theory proposes, is that it's only when all 3 of these occur that a suicidal attempt will happen. So there were only about 8 studies or 7 studies that looked at this 3-way interaction, this relationship, and fewer than half of those studies found a significant relationship. So that's partly because you need a really large study to find that effect, but it also suggests there might be some issues with the theory, with how these constructs are measured and with how the constructs relate to suicidal behaviours and suicidal thoughts. I'd just like to briefly touch on some research that's been conducted, not by myself, but by other groups in the UK, looking at whether interpersonal risk is associated with suicide in people with autism. And this study by Pelton and colleagues, it's quite recent, it was published last year, found that people with autism experienced higher levels of thwarted belongingness and perceived burdensomeness. However, that interaction effect, which I was just talking about, was only associated with ideation, with suicidal ideation in the group without autism. It had no significant association among those with autism. So it suggests that maybe these interpersonal risk factors might be less pernicious among people with autism. However, autistic traits also did influence suicidal ideation through their connection with these interpersonal risk factors of burdensomeness and belongingness. So the authors from this study suggested that promoting self-worth and social inclusion may be important approaches for suicide prevention, and this is the case for people with autism as well as people without autism. So there are a range of other theories. I won't go into detail about these other theories, but they all have a similar component to them, is that they're trying to, they suggest that there are different factors. So I've got them in blue and purple and orange here, different factors associated with going from being healthy to experiencing distress and defeat, and then going from that to transitioning into suicidal ideation, and then transitioning from suicidal ideation to attempt. There are different risk factors that underlie those different transitions over time. So a couple of the prominent theories are listed there. The integrated motivational volitional model, which is another long term for a model by Rory O'Connor and colleagues, and a couple of others theories there, which have a similar focus on trying to differentiate between the processes involved with people who develop suicidal thoughts compared to those who develop suicide attempt. So summarising this research, there are a range of diverse risk factors for suicide, and there are different processes that underlie the development of suicidal thinking versus suicide attempts. But a consistent finding in the literature is that unmet needs for social connection, as well as not feeling valued, may explain suicidal distress in many people. So in the next section, I'm going to talk a bit about what we can do to prevent suicidal behaviour. So first, a brief summary of some of the approaches that have been shown to be highly effective in previous research. Firstly, access to treatment. Obviously, psychological therapies and antidepressants have been shown to markedly reduce risk for suicide. So this work comes from, the summary comes from a study which looked at suicide deaths specifically. And they found that based on all the literature to date, there is evidence that psychological therapy and antidepressants are effective for reducing suicide deaths. Similarly, means restriction, so restricting people's access to the common methods of suicide reduces suicidal deaths and suicide behaviours. Prevention training for frontline health workers, particularly, including GPs, has a positive effect on reducing suicide. And there's some evidence that school-based programs that support young people through education and connection to trusted adults can reduce suicidal behaviour in young people as well. Continuity of care after a suicide attempt. So after people have a suicide attempt, that's a really high risk time. There's much higher risk of suicidal behaviour after a suicide crisis. So ensuring that people, after they have a suicide attempt, come into an emergency department or see their GP, it's important that they have strong continuity of care and are appropriately supported after that suicide attempt, because all too often in hospital departments, in emergency departments, they just focus primarily on the physical needs of people who've attempted suicide and less on connecting them to care and their mental health needs. There's a range of other possibilities which have been shown to, in many studies, reduce ideation and potentially reduce suicide attempts, but there's limited evidence for their effect on suicide deaths. Things like screening for suicidal thinking, educational programs for the general public, the incorporation of media guidelines so that reporting of suicide in the media is responsible and follows appropriate guidelines to reduce the likelihood of copycat suicide attempts. Gatekeeper training, so training sort of key people within an organisation to support people who might be suicidal. And then internet intervention. So it's only sort of over the last 10, 15 years that internet-based therapies have been made available and tested in terms of whether they reduce suicidal thinking. And there's mixed evidence for this. So I've been involved in a number of trials looking at the effects of internet programs, internet-based therapy on suicidal ideation. And it's difficult to demonstrate that effect, that there is some evidence that they can be beneficial for reducing suicidal ideation, and a lot of evidence that they can reduce depression and anxiety symptoms as well. So I'm going to focus a bit on the access to treatment side of things, how people engage with treatment, and some of the work we've done around stigma. So there are a number of reasons that people find it difficult to access care. There is a number of structural barriers, such as the time and the cost it takes to engage in professional care, the availability of services and access to transport. People in rural areas find it more difficult to access care. There's also a range of personal barriers, such as previous experience, which might be negative experience of health services, perceived need, whether somebody feels like they need to have professional support, self-reliance, which is the idea that you can take care of problems by yourself, which a certain level of self-reliance is helpful, that you can sort of take care of things by yourself, but very high levels of self-reliance may mean that people don't go and seek help when they need it. And two other areas are stigma and literacy, which is an area where we've done quite a bit of research. So stigma refers to negative attitudes or behaviours towards a group of people, which is based on negative stereotypes. And we've looked at suicide stigma specifically in our research. And mental health literacy is public knowledge. So it's basically just knowledge, knowing about facts about things like risk factors, causes, signs or symptoms, and treatments for mental health problems. And that's also been applied to understanding about suicide prevention, so knowledge about suicide prevention. So a few years ago, we developed the Stigma of Suicide Scale. This is the short form of the Stigma of Suicide Scale. It's got 16 items which measure a range of different attitudes. There's stigma, items about stigma, there's items about attribution of suicide to isolation, and there's items about the glorification of suicide. So people are asked to rate each of these items on a 5-point scale based on how much they agree with whether a person who dies by suicide meets these descriptors. And in that way, we can get a brief and fairly useful indication of how much stigma they have and how much attitudes they have around isolation and glorification towards suicide. We also developed the Literacy of Suicide Scale to measure mental health literacy related to suicide prevention. So there's 12 items in the short form of this scale. You can see here those items sort of cluster around risk factors for suicide, the nature of suicidality, and some of the signs or symptoms of suicidal behaviour and treatments or preventions for suicidal behaviour. So the ones in yellow here are the ones which are false, and the ones in white are classified as true. So our research has shown that high levels of stigma and low levels of suicide literacy lead to both poorer attitudes to professional services and lower intentions of seeking help. So high stigma and low literacy can be quite pernicious, with people being less likely to engage in professional help seeking. There's been a bit of research as well around service use in people with autism specifically. So less stigma and less social comparison are associated with greater levels of service use. So as we see in suicidality, lower stigma is good in terms of help seeking. And the authors of this study suggest there are benefits in improving public attitudes, both towards people with mental ill health and towards people with autism. And overall, as with the suicide literature, reducing barriers to seeking professional help does lead to better health outcomes overall. So I'm wrapping up now with some of the conclusions of my talk today. Firstly, take-home messages, 5 take-home messages. Firstly, there are many factors underlying suicide. It's a complex area. It's important to differentiate between suicidal thoughts and suicidal behaviours. There are different factors underlying those two different things. I went over the interpersonal psychological theory and some of the evidence for that theory that we've shown from our research. And that suggests that there's an unmet need for social connection, which underlies a lot of suicidal distress. I summarised some of the effective approaches to preventing suicide, and there are many of those, some of which need more evidence, but there's a lot of effective approaches, and it's likely that a combination of different approaches is needed to prevent suicide in the community. Getting professional support early is important, and our research shows that, but there are a number of different influences around whether people do seek help, and these include suicide stigma and suicide literacy. So I'd like to thank my many collaborators in the research that I've presented today, and thank you for the Society for inviting me to talk today, particularly to Darren, and I acknowledge my funding from the National Health and Medical Research Council, and I'm happy to take any questions.
Wonderful. Thank you so much, Phil, for that talk. There was some very important topics in there: help seeking, stigma. You talked about things that are working, which is great to hear. You gave us some places that we need to work on. So very helpful. I'd now like to invite you, Phil, for some time for questions from the audience. So I will just refresh and see what's been coming in. So our first question, Phil, is have the basic psychological needs from the self-determination theory, including the autonomy, competence, and relatedness, been investigated in relation to suicide risk?
That's a good question. I'm actually not aware of research looking at that specific theory. I'm sure that's an area that's open to some interesting investigations there, but I'm not aware of any research that specifically looked at that theory. Something to look into.
Cool. Thanks, Phil. Thanks, Helen, for the question. Our next question is, I was wondering, what does suicide behaviour entail? Is it suicidal thoughts or suicide attempts?
Yeah, so suicidal behaviour is sort of a broad umbrella term for any behaviour that's moving towards a suicide. So that could include both suicide attempts and suicidal deaths, because we sort of cluster those together because there is obviously a suicide attempt involved in a death. So we sort of broadly cluster those under the umbrella term of suicidal behaviour. So yeah, sorry I didn't make that clear in my talk, but that's often used interchangeably. But yeah, suicidal behaviour involves any sort of behaviour moving towards a suicide with an intention of dying.
Yeah, thanks, Phil. No, it's in this area of research, there's so many words, suicidal behaviour, thoughts, intent, attempt. So it's good to talk about those. Thank you for that question. So we have a question from Lyndall. To what extent is rejection throughout life associated with the high prevalence of mental health problems with autistic people?
I think that's probably an important factor. As I suggested through my talk, there's a number of different risk factors that impact on suicide risk. And a lot of those are likely to be higher among autistic people. So the feeling that you're rejected by society would definitely feed into both feelings of less strong feelings about belongingness, so feelings like your belongingness from society is thwarted, and also a perception that that you're a burden on other people, which is unlikely to be true, but often people have these thoughts that they're a burden on other people, and these can be strong risk factors for suicide. So feeling that you're constantly rejected obviously would feed into both of those sort of constructs and make people feel like they're less valued by society, which can be a huge risk factor for suicide. But some of the research on the interpersonal theory suggests that those sorts of interpersonal factors are actually less pertinent for autistic people. So it's a bit unclear. Then we need to do some more research to understand that. But obviously feeling like you belong and feeling like that you're valued in society and you have a place is really important for people's mental health and well-being.
Yeah, thank you for that, Phil. That was a good question and an important response there. I read somewhere once that LGBTIQA plus people experience up to 60 instances of rejection per day. And there was a similar number if there's an intersecting minority group, including autism. If they're autistic, they can be rejected from the LGBTI space. And if they're LGBTI, they're rejected from the autism space. So definitely important to be aware of how that adds to the suicide risk. So thank you.
And I think that intersections between those different risks and different identities can be quite challenging and increase risk. But yeah, we know that's the case, particularly with stigma and with rejection. Yeah,
definitely. So our next question, I have encountered youths that go through cycles of overdosing, self-harm and suicide attempts. Can suicidality be a cry for help or attention? What can we do?
In most cases, suicidality isn't just a cry for attention. There is a strong association though between non-suicidal self-harm, which is people when they injure themselves without the intention of dying. There's a strong association between that and future suicide attempt. Although, as I said in the talk,
the vast majority of people who self-harm or who have suicidal thoughts don't go on to have a subsequent suicide a suicide attempt, or go on to die by suicide. But yeah, there are, I guess these are all sort of closely associated. These are risk factors such as substance use as well is a important risk factor for suicidal behaviour. So like the question suggests, there can be sort of these cycles of, and it's hard to break those cycles of self-harm and moving towards suicide attempt. So it's important that prevention programs are available, that people get help early, that early intervention is prioritised, so that people don't sort of go down that path towards a suicide attempt.
Yeah, no, thank you for that, Phil. And it reminds me of one of the speakers earlier today saying suicidal behaviour can also be a form of escape, I guess, rather than that cry for help. So
that's right. Yeah, it's usually in response to overwhelming emotional pain, and it's when somebody doesn't have other coping mechanisms, they often resort to self-harming behaviours. That's correct.
Yeah, that's a good point. Lack of coping strategies. So a good thing to focus on. Okay, Lisa has a question for us. Can you please explain high mastery in greater detail and its role in increasing risk for suicide?
Yeah, so that's an interesting one. So mastery is sort of like self-efficacy. It's the feeling that you can do things for yourself. It's feeling that you have the ability to enact change in your life. So we actually found in one of our papers, I showed that image of the different risk factors for suicidal ideation, suicide attempt, for suicidal capability versus perceived burdensomeness. So higher mastery was associated with higher capability for suicide. So people with high mastery might feel like they have a greater ability to enact self-harm, which is obviously a dangerous sort of situation to be in. So it could be the case that there's a sort of happy medium between having high mastery versus low mastery. So on the other hand, people who don't feel like they can take control of their lives who have low mastery, therefore had higher perceived burdensomeness. They felt like they were more of a burden on others. So like the self-reliance, which I also talked about, there might be sort of a happy medium of not having really high mastery, feeling like you can take action and want to take action, but versus having low mastery, where you feel like you can't, you're sort of stuck and you can't sort of change the things that matter in your life. So there's sort of opponent processes there that having certain levels of mastery might be problematic at different stages of the suicidal experience.
Yeah, that fine balance of everything coming together. All right, thank you, Lisa, for that question. We have another question from Emily. They're asking, could you please go over known protective factors that can counterbalance risk factors?
Yeah, that's a good question. I mean, protective factors, I sometimes see protective factors as the opposite of risk factors. So having good social supports, obviously good social connections, not being isolated, having the psychosocial supports in place, so having access to employment and education is obviously protective against suicide. Not experiencing trauma, those sorts of things, but that's quite hard to modify. And then we're thinking about sort of how we sort of modify these sorts of issues in interventions and in therapy. So strengthening people's coping skills so that they have other ways to cope when they are going through distress, and when they do feel overwhelmed, so that the first thing that they go to is not self-harm and not thinking about suicide. So replacing those sort of coping strategies with other coping strategies is really important. And then obviously reducing mental health problems such as depression, treating mental health problems such as depression, anxiety, and also reducing substance use can be protective against suicidal behaviour. So there's a range of things you can do to sort of minimise these risk factors these could be seen as protective factors. If you think of sort of the flip side of what the risk factors are, a lot of those are protective against in reducing the risk of suicidal behaviour.
Yeah, awesome. Some great areas to focus on there at every level. That's some really great ideas. Thank you, Emily, for that question. So we have another question from Teresa. And her question is, rigid thinking can be an autistic trait. Is there a mode of counselling that's more successful with autistic people committed to thinking around being a burden?
Yeah, that's another great question. I wish I knew the answer to it. Like others, I'm not a clinician, so I don't practice, and I don't. My research isn't specifically with autistic people, but I do understand that there are certain characteristics of autistic people that may make therapy more difficult to engage with. So I suspect that sort of providing practical solutions and less sort of abstract thinking. I mean, cognitive behavioural therapy is quite challenging for anybody to do. So thinking about making it as concrete as possible for people who do think, who are neurodiverse, I think is important. Like I say, I'm not a clinician, but thinking about ways to deliver these sorts of treatments that are effective for reducing suicide risk, I think is important.
Yeah, no, that's a really good point and a good question. It reminds me of a previous comment earlier today when someone asked back in 2002, when someone mentioned if someone is said to be treatment resistant, could they be autistic? And I think often if sort of classic CBT and the usual things aren't working, that can be another sort of flag to say, well, is there something else going on? Similar to one of our lived experience panel members today mentioned, often when people are burnt out, CBT is trying to get them to do more when they need to be doing less. So I think it can be a good indicator if the classic stuff isn't working or helping.
Absolutely.
Often think about neurodiversity. Cool. We have a question from Bob. Is intellectual disability a protective factor?
I saw the presentation before with the review that suggested that the risk wasn't as elevated. The risk of suicidal behaviour wasn't as elevated in people, autistic people who had intellectual disability compared to those who did not have intellectual disability. So that would suggest it is a protective factor against suicide death, but I'm not sure if that also holds for suicidal ideation. That's an interesting question. Yeah, I'm not familiar with the data around that specifically, but it does suggest that there are lower rates in those with intellectual disability compared to those without.
Thank you for that question. Maybe that could be more data for next year's ASFAR conference. We can touch base on all the things we're not sure of yet. Well, we have a couple of minutes left for questions. I'll see if anything else pops in. And I guess while we wait a couple of minutes, I'll throw one in there. You mentioned a negative previous experience with help seeking stops people from getting help in future. How do you think we can get around that?
Yeah, that's tough. I mean, it's hard enough to get treatment as it is, and then when people have a bad experience, that can put them off. I mean, I think it's important to set expectations when people are seeking treatment. That when they first talk to their GP, it's not that it's unlikely they're going to find a great match with a psychologist straight away. It's possible they won't find a great match with their psychologist straight away. So nothing works perfectly for anybody. So it's always a matter of shopping around, trying different options. I do a lot of research in digital interventions. Obviously, I mentioned that in the presentation. So trying a few different things, seeing what works, seeing what's most helpful, and not expecting that you'll have those sort of magic bullet straight away. It's about sort of finding out different things that might work for you, working out what's best, and that could be a range of different things, including therapy, including lifestyle changes, and including medication. So trying a range of different things and seeing what helps. It's a process and it takes time. So setting expectations early and upfront that this is a complex response to a complex problem.
That's a really good point, not giving up, keep trying, try a couple more until you find a good fit. Yeah. Alrighty, well, we might have time for one last question, which is there research on the application of art therapy with people with autism and mental health?
Yeah, like I said, I'm not a specialist in autism research, autism and mental health research, but I know that art therapy can be very useful to support people with depression and anxiety. So I'm sure that might be helpful for a lot of people and autistic people who find art therapeutic or useful in expressing their emotions. I can imagine that would be quite useful. I'm not across the literature in that area, but I can imagine that would be useful. Again, it's about trying different approaches. For some people, art therapy might be a really helpful thing. For other people, it might be other things. So yeah, I wouldn't rule out art therapy, but yeah, not sure about the evidence specifically for that.
Another good one for next year.
Yep.
But yeah, it makes sense. It's a non-verbal option, which often when autistic people are distressed, they shut down. So would make sense. Well, Phil, is there anything else that you would like to add before we wrap up this session?
No, nothing else to say really, apart from thank you all for sticking around for the last session of the day. And great that you've got through this far, and thank you to Asfar and to Darren for inviting me to present today and talk about some of my research. I'm working with Darren on better screening for suicide risk in autistic people. It's some really exciting research, and I think more needs to be done in this space. So thank you very much.
Awesome. Thank you so much, Phil. Appreciate your time and input.
Thanks.
All right, everyone. Well, thank you for another great session. Thank you for your questions. That concludes our speeches and panels for today. So I would like to thank everyone for their participation. A special thank you to our sponsors again, Auticon, the Autism CRC, Amaze, Aspect, Different Journeys, the Emotions Clinic, Untapped, and the Suicide Response Project. Definitely encourage you to check out all of their websites. They have amazing resources, whether you're a parent, family member, teacher, work in emergency services, allied health, really helpful stuff. I also really want to thank our organisers of this conference. So I'm sure there's heaps of people in the background, but I know of Radhika, Melinda, Karen, Mick, Alex, Darren, of course, and there's many others. So it's brilliant. Today's been really, really great. The platform's amazing too. So thank you for all your hard work. I think what stands out to me today is we need a lot more acceptance and advocacy. We need to work on addressing the stereotype of autism and neurodiversity. We need to look more at intersectionality. We need to work together. We need to take self-harm and suicide attempts seriously and notice it as burnout, and that something needs to change around people. And that autism isn't something that needs to be fixed. It's something that needs to be understood and heard and supported. So I've got a lot out of today. I hope everybody else has gotten something out of today. I know you will have. Just a reminder, everything is still available on the platform for the next 60 days. So check out more posters, interviews, transcripts, and you can grab the contact details if you'd like to talk to any of the speakers today.